trauma CNS injury, concussion. Cranial injury trauma must be extreme to fracture basal skull linear. Depressed, open, impaled object, basal skull, unprotected, spaces weaken structure, relatively easier to fracture. Cranial injury basal skull fracture signs battle signs raccoon eyes. Retroauricular ecchymosis, associated with fracture of auditory canal and lower areas of skull. Raccoon eyes. Bilateral parorbital ecchymosis, associated with orbital fractures. Cranial injury basilar skull fracture may tear dura. Permit CSF to drain through an external passageway. May mediate rise of ICP. Evaluate for target or halo sign. Brain injury as defined by the National Head Injury Foundation. A traumatic insult to the brain capable of producing physical, intellectual, emotional, social and vocational changes. Classification: direct, primary injury caused by forces of trauma. Indirect, secondary injury caused by factors resulting from the primary injury. Direct brain injury types: coup, injury at site of impact. Contre-coup, injury on opposite side from impact. Direct brain injury categories: focal, occur at a specific location in brain. Differentials: cerebral contusion, intracranial hemorrhage, epidural hematoma, subdural hematoma, intracerebral hemorrhage. Diffuse, concussion, moderate diffuse axonal injury, severe diffuse axonal injury, focal brain injury, cerebral contusion, blunt trauma to local brain tissue, capillary bleeding into brain tissue, common with blunt head trauma, confusion, neurologic deficit, personality changes, vision changes, speech changes, results from coup contra coup injury, focal brain injury, intracranial hemorrhage, epidural hematoma, bleeding between dura mater and skull, involves arteries, middle meningeal artery most common, rapid bleeding and reduction of oxygen to tissues, herniates brain toward foramen magnum. Focal brain injury, intracranial hemorrhage, subdural hematoma, bleeding within meninges, beneath dura mater and within subarachnoid space, above pia mater, slow bleeding, superior sagittal sinus, signs progress over several days, slow deterioration of mentation. Focal brain injury, intracranial hemorrhage, intracerebral hemorrhage, rupture blood vessel within the brain. Presentation similar to stroke symptoms. Signs and symptoms worsen over time. Diffuse brain injury due to stretching forces placed on axons. Pathology distributed throughout brain. Types: concussion, moderate diffuse axonal injury, severe diffuse axonal injury, diffuse brain injury, concussion, mild to moderate form of diffuse axonal injury, DAI, nerve dysfunction without anatomic damage, transient episode of confusion, disorientation, event amnesia. Suspect if patient has a momentary loss of consciousness. Management: frequent reassessment of mentation. ABCS: diffuse brain injury, moderate diffuse axonal injury. Classic concussion. Same mechanism as concussion. Additional, minute bruising of brain tissue. Unconsciousness, if cerebral cortex and RAS involved, may exist with a basilar skull fracture. Signs and symptoms: unconsciousness or persistent confusion, loss of concentration, disorientation, retrograde and antegrade amnesia, visual and sensory disturbances, mood or personality changes, diffuse brain injury, severe diffuse axonal injury, brainstem injury, significant mechanical disruption of axons, cerebral hemispheres and brainstem, high mortality rate. Signs and symptoms: prolonged unconsciousness, Cushing's reflex, decorticate or decerebrate posturing, intracranial perfusion. Review: cranial volume fixed, 80% equals cerebrum, cerebellum and brainstem, 12% equals blood vessels and blood, 8% equals CSF. Increase in size of one component diminishes size of another. Inability to adjust equals increased ICP. ECO2 monitoring. Physiology of the respiratory system. Respiration and ventilation. Respiration is the exchange of gases between a living organism and its environment. Ventilation is the mechanical process that moves air into and out of the lungs. The respiratory cycle. Pulmonary ventilation depends upon changes in pressure within the thoracic cavity. Coordinated interaction among the respiratory system, the central nervous system, and the musculoskeletal system. The respiratory cycle. Inspiration. Thoracic cavity is closed except for the tracheal opening. Respiratory centers stimulate nerves which stimulate muscle. Changes in pressure occur with diaphragmatic contraction and intercostals contract and air is drawn inward. Active process. The respiratory cycle. Expiration. Receptors signal the respiratory center by way of the vagus nerve to inhibit inspiration. Expiration occurs. Normally passive. Use of accessory muscles. Pulmonary circulation. Respiration also requires an intact circulatory system. Venous system carries the oxygenated blood to the right side of the heart, and the right ventricle pumps it into the pulmonary circulation. Pulmonary circulation. Diffusion occurs in the pulmonary capillaries. Blood returns to the left side of the heart for systemic circulation. Diffusion. Movement of a gas from an area of higher concentration to an area of lower concentration. Transfers gases between the lungs and the blood and between the blood and peripheral tissues. Measuring oxygen and carbon dioxide levels. The partial pressure of a gas is its percentage of the mixture's total pressure. 4 major respiratory gases. Nitrogen, N2. Oxygen, O2. Carbon dioxide, CO2. Water, H2O. Normal arterial partial pressures. Oxygen, PaO2, equals 100 torr, average equals 80 to 100. Carbon dioxide, PaCO2, equals 40 torr, average equals 35 to 45. Factors affecting oxygen concentration in the blood. Decreased hemoglobin concentration. Inadequate alveolar ventilation. Decreased diffusion across the pulmonary membrane. Ventilation/perfusion mismatch occurs when a portion of the alveoli collapses. Factors affecting carbon dioxide concentrations in the blood. Hyperventilation. Lower CO2 levels due to increased respiratory rates or deeper respiration. Increased CO2 production include fever, muscle exertion, shivering, and metabolic processes. Decreased CO2 elimination results from decreased alveolar ventilation. Respiratory rate involuntary, however, can be voluntarily controlled. Chemical and physical mechanisms provide involuntary impulses to correct any breathing irregularities. Nervous impulses from the respiratory center. Main respiratory center is the medulla. Apneistic center assumes respiratory control if the medulla fails to initiate impulses. Pneumotaxic center controls expiration. Stretch receptors prevent overexpansion of the lungs. Herring-Breuer reflex. Chemoreceptors. Located in carotid bodies, arch of the aorta, and medulla. Stimulated by decreased PAO2, increased PACO2, and decreased pH. Cerebrospinal fluid, CSF, pH is primary control of respiratory center stimulation. Hypoxic drive. Hypoxemia is a profound stimulus of respiration in a normal individual. Hypoxic drive increases respiratory stimulation in people with chronic respiratory disease. Measures of respiratory function. Respiratory rate. Factors influencing rate include fever, emotion, pain, hypoxia, acidosis, stimulant drugs, depressant drugs, sleep. Age. Rate per minute. Adult 12 to 20. Children 18 to 24. Infants 40 to 60. Measures of respiratory function. Respiratory capacities and measurements. Total lung capacity. Total volume of air at maximum inhalation. Average adult male TLC 6 liters. Tidal volume. Average volume of gas inhaled or exhaled in one respiratory cycle. Approximately 500 cc. Measures of respiratory function. Respiratory capacities and measurements. Dead space. Amount of gases in tidal volume that remains in the airway. Alveolar volume. The alveolar volume is the amount of gas in the tidal volume that reaches the alveoli for gas exchange. Minute volume. The amount of gas moved in and out of the respiratory tract in 1 minute. Measures of respiratory function. Respiratory capacities and measurements. Alveolar minute volume. Amount of gas that reaches the alveoli for gas exchange in 1 minute. Inspiratory reserve volume. The amount of air that can be maximally inhaled after a normal inspiration. Expiratory reserve volume. The amount of air that can be maximally exhaled after a normal expiration. Measures of respiratory function. Respiratory capacities and measurements. Residual volume. The amount of air remaining in the lungs at the end of maximal expiration. Functional residual volume. The volume of gas that remains in the lungs at the end of normal expiration. Forced expiratory volume. The amount of air that can be maximally expired after maximum inspiration. Non-invasive respiratory monitoring. Devices will assist your measurement of the effectiveness of oxygenation and ventilation. Pulse oximetry, capnography, esophageal detection, and peak flow measurements. Non-invasive respiratory monitoring. Pulse oximeter measures hemoglobin oxygen saturation in peripheral tissues. The fifth vital sign. Normal SpO2 varies between 95 and 99%. 85% or lower indicates severe hypoxia. Copyright Scott Metcalf. SpO2 and waveform plethysmograph. Optically measures blood flow to an organ. Non-invasive respiratory monitoring. Capnography. Recordings or displays of exhaled CO2 measurements are called capnography. When perfusion decreases, as occurs in shock or cardiac arrest, CO2 levels reflect pulmonary blood flow and cardiac output, not ventilation. Non-invasive respiratory monitoring. Capnography, CONT. A normal partial pressure of end-tidal CO2, PETCO2, is approximately 35 to 45 mm of mercury. Increased ETCO2 levels are found with hypoventilation, respiratory depression, and hypothermia. Decreased ETCO2 levels can be found in shock, cardiac arrest, pulmonary embolism, bronchospasm, and with incomplete airway obstruction. Non-invasive respiratory monitoring. Capnography. Colorimetric device. Contains pH-sensitive paper. Causes a color change in the paper. Electronic devices. Use an infrared technique to detect CO2. May be either qualitative or quantitative. Reprinted by permission of Nel Copyright and Bennett LLC, Pleasanton, California. Copyright Scott Metcalf. Non-invasive respiratory monitoring. Capnography, CONT. Clinical application. Allows continuous monitoring of airway placement and ventilation for intubated patients. Monitoring non-intubated patients. Useful in CPR. Rise with the onset of effective CPR. Copyright Scott Metcalf. Non-invasive respiratory monitoring. Esophageal detector device. May be either a rigid syringe or a bulb syringe. Copyright Wolf Torrey Medical, for therapy. Catheters. Sizes 24-14 Ga. Varies in model types. Components. Ivloc. Saline. Heparin. IV tubing. Medication bag. Fluid administration. Administer up to 250 ml of saline. Medical control option for 250 ml or more. Indicators. Excessive bleeding. Blood pressure below 100 mm Hg. Suspected dehydration. Suspected internal bleeding. Field triage and patient assessment. Priority determination. Once the initial assessment is completed, determine the patient's priority. If serious injury or illness is indicated by the initial assessment, conduct rapid head-to-toe assessment for other potential life threats and initiate transport. Top priority patients: poor general impression, complicated childbirth. Unresponsive. Conscious but cannot follow commands. Difficulty breathing. Hypoperfusion. Complicated childbirth. Chest pain and BP below 100 systolic. Uncontrolled bleeding. Severe pain. Multiple injuries. Expedite transport for a high-priority patient and continue assessment and care en route. Copyright Glenn Jackson. The Focused History and Physical Exam. Types of patients: trauma patient with significant mechanism of injury. Trauma patient with isolated injury. Responsive medical patient. Unresponsive medical patient. The major trauma patient. Sustained significant injury. Exhibits altered mental status from the incident. Evaluate the trauma scene to determine the mechanism of injury. Copyright Robert J. Bennett. Predictors of serious internal injury. Ejection from vehicle. Death in same passenger compartment. Fall from higher than 20 feet. Rollover of vehicle. High-speed motor vehicle collision. Vehicle-passenger collision. Motorcycle crash. Penetration of the head, chest, or abdomen. More considerations for infants and children. Fall from higher than 10 feet. Bicycle collision. Medium-speed vehicle collision with resulting severe vehicle deformity. A bent steering wheel indicates potentially serious injuries. Courtesy of Edward T. Dickinson, MD. Rapid trauma assessment. Not a detailed physical exam. Fast, systematic assessment for other life-threatening injuries. Findings may influence transport decision. Decap, BTLS, deformity, contusion, burns, abrasion, tenderness, penetration. Lacerations. Swelling, deformity. Contusion. Abrasions. Penetrations. Burns. Superficial. Partial thickness. full thickness, tenderness, laceration, swelling, hemorrhage and tourniquets. Hemorrhage assessment. Scene size up. Standard precautions are essential. Evaluate the mechanism of injury. Time elapsed since injury. Determine the amount and rate of blood loss. Copyright Jeff Forster. Hemorrhage assessment. Primary assessment. General impression. Obvious bleeding. Mental status. ABC. Interventions. Manage as you go. O2. Bleeding control. Shock. Bless before ALS. Hemorrhage assessment. Secondary assessment. Rapid trauma assessment. Full head to toe. Consider rare medical if stage 2 plus blood loss. Focused physical exam. Guided by CC. Vitals, sample, and OXT. Additional assessment. Search for signs of internal bleeding. Bleeding from body orifice, melena, hematochezia. Orthostatic hypotension. Hemorrhage assessment. Ongoing assessment. Reassess vitals and mental status. Q 5 minutes, unstable patients. Q 15 minutes, stable patients. Reassess interventions. Oxygen. ET. 4. Medication actions. Trending, improvement versus deterioration. Pulse oximetry. End-tidal CO2 levels. Hemorrhage management. Assure that the airway is patent and breathing is adequate. Maintain the airway and provide the necessary ventilatory support. Administer high-flow oxygen. Carotid pulse. CA. Assure that the patient has a palpable reef or serious, arterial and heavy venous, hemorrhage, immediately after you correct airway and breathing problems. Hemorrhage management. Direct pressure. Controls all but the most persistent hemorrhage. If bleeding saturates the dressing, cover it with another dressing. If ineffective, may be necessary to visualize wound to apply pressure directly to site.